President Donald Trump's new executive order on lowering drug prices is being heralded by his administration as a bold step toward making healthcare more affordable for Americans. But beneath this sweeping language and high-profile Rose Garden signing ceremony lies a complex and deeply contradictory agenda, one that may deliver fewer benefits than promised while introducing a host of new problems that could worsen access, affordability, and transparency in the long run. The directive is being positioned as a cost-cutting initiative, with Trump vowing to outdo the Inflation Reduction Act's drug negotiation provisions, which were crafted under the Biden administration and marked the first time Medicare was allowed to negotiate drug prices directly. While the optics of lowering drug costs are politically appealing, the administration's simultaneous push to impose tariffs on pharmaceutical imports undercuts the core goal. Experts have warned that such tariffs could significantly drive up drug prices in the short term, especially for medications manufactured or sourced abroad, a substantial portion of the U.S. pharmaceutical supply chain. Tariffs could create bottlenecks, disrupt availability, and in some cases, lead to outright shortages, putting lives at risk and further burdening already strained healthcare systems. The fact that many of the executive order's key provisions require congressional approval adds another layer of uncertainty. Several components, including changes to Medicare's negotiation timelines and payment equalization reforms, would have to survive the volatile and divided political environment of Congress. Without legislative support, much of this order amounts to little more than political posturing. Moreover, the administration has not clarified how it intends to fund or implement the reforms, nor has it addressed the administrative burdens that could be passed down to health centers and providers. The lack of detail raises serious concerns about how these changes would work in practice and whether they might create new inefficiencies or inequities. Of particular note is the directive to reevaluate Medicare's drug price negotiation framework. Trump's administration aims to level the playing field between large molecule biologic drugs and small molecule medications by adjusting eligibility timelines. Currently, biologics avoid negotiation for 13 years, while small molecule drugs face it after 9. But any attempt to delay negotiations across the board, particularly for small molecule drugs, would be a clear win for pharmaceutical companies and a loss for patients. The industry has long lobbied for such delays, arguing that early negotiations stifle innovation. In reality, postponing these discussions allows drug makers to maximize profits from monopolies for longer, driving up costs for both the federal government and consumers. Also troubling is the administration's renewed focus on site-neutral payments, standardizing Medicare reimbursement regardless of care setting. Though marketed as a way to eliminate inefficiencies and reduce costs, the implications for rural and smaller hospitals are alarming. Many of these facilities rely on higher reimbursements to stay afloat due to lower patient volumes and higher operating costs. Previous attempts to enact broad site-neutral reforms have been met with bipartisan resistance for this reason. If Trump's more targeted proposal results in sweeping cuts without adequate compensation or reinvestment, it could lead to closures, layoffs, and reduced access to care in underserved areas. The order's call to import prescription drugs from other countries, mainly Canada, also rehashes an old promise with limited practical feasibility. Despite authorization under the Biden administration, only Florida has successfully received FDA approval, and Canada itself has expressed concerns about its own supply being undermined. Without cooperation from foreign governments or a framework that ensures safety and quality, these importation schemes risk becoming more symbolic than substantive. Trump's directives also take aim at the opaque world of pharmacy benefit managers, PBMs, demanding greater transparency around fees and broker incentives. While this might appear to be a populist crackdown on middlemen blamed for inflating prices, critics argue that the order lacks enforcement mechanisms and real teeth. The PBM industry, with deep ties to insurers and drug manufacturers, has weathered years of scrutiny without substantive change. Voluntary disclosures and vague transparency goals will likely have minimal impact without binding regulatory action. Perhaps most concerning is the potential restructuring of the 340B drug pricing program, which provides discounted medications to hospitals serving vulnerable populations. While some critics claim the program is exploited by large institutions, any effort to reduce its scope or shift its administration without robust oversight could gut essential safety nets. Community hospitals depend on these discounts to subsidize care for uninsured and low-income patients. If Trump's Medicare-led survey leads to rules that restrict 340B eligibility or redirect funds, the effect could be devastating for public health services in economically fragile regions. Even the plan to stabilize Part D premiums, seemingly a protective measure, must be viewed with skepticism. The Biden administration had already taken steps to prevent premium spikes caused by the IRA reforms. Trump's order suggests further recommendations, but the language is vague and fails to address how these goals would be reconciled with ongoing budget cuts and pressure to reduce federal spending. There's a high risk that efforts to lower premiums could be offset by reductions in coverage, higher out-of-pocket costs, or narrower formularies, ultimately hurting seniors. In sum, while the executive order is pitched as a comprehensive strategy to lower drug prices, its contradictions, omissions, and deference to corporate interests cast doubt on its sincerity and effectiveness. Provisions that might offer modest savings are often paired with destabilizing policies like tariffs or deregulation. Key promises rely on legislative cooperation that is far from assured. Meanwhile, communities that are already struggling, rural hospitals, safety net clinics, and low-income patients, could face greater uncertainty and harm under these changes. Rather than delivering on the promise of affordable, accessible medicine, this executive order risks cementing a system where price controls are weakened, corporate profits are protected, and healthcare inequities are deepened. If history is any guide, bold language and flashy directives may once again yield little lasting reform, while leaving the most vulnerable Americans to navigate the fallout.